Dr. Kayci Vickers and Dr. Goldstein, would you guys like to introduce yourselves? Unpin myself.
Actually, absolutely. I'm Felicia Goldstein. I'm a clinical neuropsychologist. I've been at Emory for many, many years. I did my doctorate degree in the psychology department here and left for 5 years Atlanta and then loved it so much that I wanted to come back here. And I've been with the cognitive neurology group in the Alzheimer's Center now and the cognitive empowerment program more recently. And Kayci? Yeah.
I'm Kayci Vickers. So I am a postdoc in clinical neuropsychology. So I work with Dr. Goldstein. And I've only been at Emory for 3 years, but I also really love Atlanta. And prior to this, I was in Philadelphia. So I made a big move here. And I work primarily within the cognitive empowerment program.
Okay, so everyone, Dr. Goldstein and Dr. Vickers are going to be giving us a presentation today. Please stick around after their presentation. We're going to be answering questions and answers afterwards. And yes.
Matt, can you allow me to share my screen?
Yeah, no problem. Hold on one
Thank you.
second.
If not, Kayci may be able to. No. Yep, we're disabled here.
Did that work now, Dr. Goldstein?
Yes, it does. Good. Thank you, Matt.
Yeah, no problem.
All right, everybody. Well, welcome to Community Live. And Dr. Vickers and I today are going to talk about mild cognitive impairment. What is it and what can you do about it? I found through the years that the doctors, are busy in their clinics and they tell you that you have this mild cognitive impairment, but it's not always really clear what it is. So first part, going to go through what it is, how you diagnose it. And then in the second part, Dr. Vickers will talk about some of the things we're doing in the cognitive empowerment program, but that you don't have to be in the program to do that have been found to be beneficial for protecting your brain health. So let me go ahead and start my show here. Set from current slide. Okay, and if you'd like, as we're talking, Matt is going to monitor any questions you may have, and at the end we'll have time for questions and answers. So please feel free to type in anything that's not clear or that you want to bring up that we haven't covered here. So, I just wanted to do a brief introduction here with what normal cognitive aging is, because it's not always clear. And I see a lot of people come in to the clinic who report that they're experiencing some difficulties. And some of these are just part of normal cognitive aging. And as we age, we know that, first of all, our brain does change. In general, there may be some atrophy of the brain, some shrinkage, not a lot, but each year we lose some brain cells and the brain gets a little bit smaller. Also, some different brain structures change as well. For example, the temporal lobes, where we find the hippocampus for memory, may get a little bit smaller, but that's just part of normal aging. Most commonly for everybody getting older, even beginning at age 30, really, we notice a change in the speed at which we process information. So for those of us who are older, we may note that, we're a little bit slower at performing tasks, at making decisions. Maybe, we need a little bit more time to retrieve information. We remember it, it's in there. It just takes longer to get it out. Maybe also note, however, that there's some good news about getting older. Unlike younger people, people who are older have what's known as an increase in their wisdom, in their expertise, and in their vocabulary. Bottom line is we've been around longer, and so we get wiser. Some of us do, at least. We've been exposed to more experiences. We know how to solve things better than we did when we were young. Certainly our vocabulary may increase. We've read more. We've been exposed to more words and vocabulary and higher meaning words as we get older. So that routinely, by the way, does improve with age. And I want to emphasize that these changes that I've mentioned here are all part of normal aging. Um, so it's normal to experience some of these things. So what is mild cognitive impairment? Well, I went over a little bit, beginning at around 30, but really showing here around age 50 in that box. People notice some decline in abilities, the black line, that's normal. Certainly, people in the green curve there show a very sharp decline in their cognitive abilities, shown in that line on the left. Their cognition definitely can take a dive into what we call dementia. But there are people in this mild cognitive impairment stage shown in the box where they're a little bit experiencing more problems than normal aging, but they're still not as severe as somebody who may have dementia. And what do we mean by that? Well, there's a preclinical stage, and some of what we see in the clinic is when people come in and they say to us, I'm not as sharp as I used to be. I know something's wrong. Yet they may get tested by us, they may see the cognitive neurologist, and there's nothing showing up on objective testing. And this is called the stage where the patient knows, but the doctor doesn't. But then there may be a transition for those folks who are having subjective concerns, but nothing objective. There may be this intermediate step of mild cognitive impairment. Here, the cognitive changes are causing concern by the individual, but also by other people are starting to notice. Family members, friends may start to notice that things aren't quite as sharp as they used to be. One or more cognitive domains can be affected, like, for example, memory might be the area you might notice. Coming up with words, which, by the way, is normal for age. Well, everybody has some word finding difficulty, but it's a little bit more, than just forgetting one or two words. It's coming up a lot in speech. The important thing about mild cognitive impairment and what sets it apart from dementia is preserved activities of daily living. So even though you have some mild cognitive impairment in terms of your cognitive abilities, you're still doing well in the environment. You may be working, you may be driving, managing your own medications, doing all your activities of daily living, and they're okay. Or maybe you need a little bit of help from family, but you're pretty independent. When the doctor tells you that, when you are told that you are in the MCI stage, dementia, the difference is that now the cognitive impairments are severe enough to interfere with everyday activities. So now you are unable to manage your day-to-day affairs without significant help from others. So you need constant reminders to take medications. Cooking may become an issue, leaving on the stove. It's no longer safe to drive. And that's the difference right there. So if any of you have come to our cognitive neurology clinic, you may have been asked to fill out a questionnaire about functional activities of daily living. And this is an example of one of the forms our cognitive neurologists give families, is to rate the person on how independent they are in performing different abilities. So 0 means no difficulty, can do fully independently. 1 means needs a little bit of help in that, but still independent. Up to 2 and 3, where the person needs considerable help from other people. And the types of activities we ask about are things like writing checks, doing taxes, turning off the stove, keeping track of current events, remembering appointments, etc. People with mild cognitive impairment get scores usually of 0, meaning they're doing okay, may get some 1s. And they are people we would then classify as having mild cognitive impairment because the cognitive abilities are not severe enough to interfere with everyday ability activities. So when your doctor tells you that a family member or you have mild cognitive impairment, they're saying that there's an acquired disturbance in cognition without an impairment in daily functioning. However, they're not telling you what the cause of that is. So we call mild cognitive impairment an umbrella term, meaning that it's a descriptor, but it doesn't say what is the cause of that mild cognitive impairment. And I always talk about, when you have a fever, a temperature um, elevated temperature, but that doesn't mean that the cause of what's uh, causing that elevated temperature is known. And that's when you go for workup to try to figure out why are you showing a spike in your temperature. So typically to work up the cause of mild cognitive impairment, people go through a number of different uh, things here. Most likely, if you have been seen in our clinics at Emory, the doctor will order blood tests to rule out causes such as vitamin B12 deficiency, thyroid level could also cause cognitive problems. They want to try to rule out or figure out whether that's the problem. Most likely you get brain imaging, and the purpose of the brain imaging is to help figure out whether it might be little strokes, vascular disease that's causing the mild cognitive impairment. You might have a tumor. You could have multiple sclerosis. Maybe you fell and you have a subdural hematoma. They want to figure out what the cause of that is through the imaging. Some of you and family members may have had cerebral spinal fluid drawn, a lumbar puncture. That helps the doctors figure out whether or not you're showing abnormal levels of brain proteins found in Alzheimer's patients of A, beta, and tau. It helps the doctor diagnose. If the values are suspicious, they may then say, it looks like the cause of your MCI is Alzheimer's. There's also a gene, the ApoE gene, that's associated with a higher risk of Alzheimer's. So they may do blood work to test for that. You also, if you see Kayci and myself and other neuropsychologists, you're going to get neuropsych testing, and that's done in our clinic. A very brief battery is done in our cognitive neurology clinic. Sometimes the doctors may refer them on to Kayci and myself because we do more detailed testing and we can really help figure out more carefully what's going on with you. Our role is to kind of look for patterns of testing. Does it look more like Alzheimer's? Could it be vascular? Could it be depression? If it is depression that's causing your MCI, that's a good thing because it's treatable. And we could go back to the doctor and say, we recommend the person get on an antidepressant and they go for counseling. And then we may recommend seeing you in 6 months, and you may no longer be showing any mild cognitive impairment anymore. You may be back to your old normal cognition baseline. So in neuropsych assessment, what we do, and we're actually now doing computer testing because of COVID, we give you measures of cognitive and emotional functioning. Everything's very standardized. And the way we know if you are just showing normal age-related changes or something beyond normal age is we look up your scores compared to people of your age, education, and background. And we look at how those scores fall. If they fall within in these ranges, okay. If they fall outside, you're way beyond what was normal, considered normal, low average to high average. We're suspicious that something's wrong. And as I mentioned, in the neurology clinics, they typically do about a 45-minute battery. Dr. Vickers and I do more than that. If it's called for, we may do a 2+ hour examination of you with breaks. We give you plenty of breaks. So we look at different domains. Memory, of course, we look at your language, ability to name pictures, come up with words. Executive functioning, we look at your reasoning ability. Visual motor, we have you copy drawings to see how you're at analyzing things visually. We look at visual spatial skills, how well you can judge where things are in space. Visual spatial skills are very important for driving, so it's important that we analyze that. We look at behavioral observations. Do you appear depressed, or, is there something anxious? Is there something that might be causing the performance we're seeing on the testing? And so then we come up with this profile. Amnestic MCI means that your memory's involved. You may have only memory problem, or in some cases, people have memory plus something else like language or visual spatial functioning. And there are some people with mild cognitive impairment who have non-amnestic profiles. They don't have memory involved, but something else going on. And the reason this is important for us is because it points us to certain etiologies. Typically with Alzheimer's disease, memory impairment makes us suspicious that it could be Alzheimer's. If we don't see memory, we're less suspicious of Alzheimer's. However, we know a lot more than we ever knew. And when I was starting out, you had to have memory impairment to be diagnosed with Alzheimer's. Now you don't, because we know there are some atypical presentations of people whose memory is actually okay. It's other things that are problematic. So you probably know that Alzheimer's disease is the most common cause of mild cognitive impairment, but there are many other causes, just a few shown here. There's vascular dementia from strokes. Parkinson's can cause mild cognitive impairment. Lewy body disease can, like Robin Williams or Ted Turner, have had Lewy body dementia. Many different causes. Excessive alcohol use can cause cognitive problems. So I'd like to let you know that in my many years at Emory, I've been part of the Alzheimer's Center here, and we review people that come in yearly for testing. And bottom line is there's a lot of variability in what we see. Some people we've followed for 15 years and they have remained steady. They had mild cognitive impairment maybe in year 5, went from normal to mild cognitive impairment, and they've kept mild cognitive impairment throughout. We don't think they've gone on to dementia. There are other people we've seen that do progress to dementia from mild cognitive impairment, and some in people we've seen that even improve over time. So bottom line is mild cognitive impairment is variable. Some people progress, some people get better, some people remain stable. So we don't always quite know what to expect. We certainly can't always predict a timeline either. Even if somebody's had the biomarkers for Alzheimer's, it doesn't tell us when they're going to get demented from Alzheimer's. They could go along for a long time. So we have a lot of different drug trials going on in our Department of Neurology, trying to find out drugs that can get rid of the AD pathology. Loads of trials, vaccine trials have been done, different protocols for people with mild cognitive impairment, also with people with that preclinical stage where they have a subjective complaint but are normal, nothing can be found. So we're trying very hard to find disease-modifying therapies through drugs. But what I want to also segue to Dr. Vickers is that there are also non-drug approaches that can also help. So it's been said that if we could find effective interventions to delay progression by even 1 year, that could result in 9.2 million fewer cases. So in our cognitive empowerment program, we stress physical activity, cognitive stimulation, functional independence, and emotional well-being. And even if you're not in the cognitive empowerment program, it's not open to everybody. It's open to people who are patients in the cognitive neurology clinic. But even if you don't, all of the things that you see on this screen can be a benefit to do now. Just start them now. And I'm going to let Dr. Vickers take over and go into what some of those strategies are.
Thanks, Felicia. Let me see. I'm not able to share my screen.
Okay, Dr. Vickers, just hold on 1 second.
I imagine there's like tech magic happening in the background.
There is. There's a lot of hamsters on wheels spinning right now. And Dr. Vickers, you should be able to share your screen now.
Perfect. All right. So let me see if I can get it started from here. Can you guys see my screen? Actually, 1 second. It's not going into, there we go. Can you guys?
Yep.
Perfect. So just as Dr. Goldstein said, what I'm going to talk about today are some of these behavioral interventions. You'll hear me also call them lifestyle interventions for people with mild cognitive impairment. They mean the same thing in the context of this conversation. So really what we're talking about are, what are some of those things that you can kind of add into your life that can help slow down that progression or can help kind of improve your cognition to kind of be at its best. And what I like to start off with is really talking about some of the current treatments for mild cognitive impairment. So this is taken directly from the American Academy of Neurology's practice guidelines for basically what is recommended for people with mild cognitive impairment by neurologists. And anyone who is diagnosed with MCI or has a family member with MCI, this is going to feel really familiar. And I think for a lot of people, it feels really frustrating because some of those recommendations are getting assessed yearly. So serial assessments, whether you're coming to see people like Dr. Goldstein and I, or doing that in your neurology clinic, taking those yearly tests, maybe changing up your medications if they're impacting your cognition, treating modifiable risk factors. So things like high blood pressure. Unfortunately, there are no pharmacological or medications that you can take for MCI. So getting counseling about that. And then we get into some of these behavioral strategies. So what I want to point out on this slide is that about half of these recommendations are things that all of us can be doing in our daily life and don't require some sort of medication or thing like that. They really are these behavioral interventions. So for example, exercising 2 times a week, engaging in cognitive intervention, and treating things like depression or other neuropsychiatric issues, and modifiable risk factors, which we'll talk about in just a second. So what we like to talk about are things called neuroprotective factors. These are those lifestyle factors that can help us sustain brain health even after the onset of MCI. So even for folks who have biomarkers that have been found on lumbar puncture, these factors can actually help sustain our cognition and our brain health despite those proteins. So when we look at these lifestyle factors, these are going to sound really familiar, but they're things like maintaining your health and nutrition, getting exercise, getting good sleep, staying cognitively stimulated, engaging in social activities, and supporting your mood. And what's really great about all of these lifestyle factors is they interact with one another. And I'll talk a little bit more about this later, but I think the coolest thing, and something I hope everyone takes home from this, is that there really is this synergistic effect between these different things. So if you are exercising, that also improves your mood and might improve your sleep. And if you do it with a friend, it's also a social activity. And all of that really supports your brain health. So making sure to incorporate these types of activities can be really useful. And for today, I'm going to focus on 2 of them. So I'm going to focus first on physical exercise, and then I'll also talk about cognitive stimulation. So the reason I focus on physical exercise is because if you're going to choose to make one change to help your brain, physical exercise is it. And I'll talk about what some of the recommendations are and why that is in just a second. The reason I talk about cognitive stimulation is because that's really the area of expertise of Dr. Goldstein and myself. So when we're within the CEP, we're helping with cognitive rehabilitation and using some of those cognitive stimulation techniques to help support the brain. So let's first talk about physical activity. Like I said, if you're going to add one thing to your life to help your brain, I think physical activity is where the biggest bang for your buck is. And why does exercise have a cognitive benefit? So this is where that synergy comes in. So physical exercise impacts a lot of these lifestyle factors. And what we know from the literature is that physical exercise lowers the risk of developing chronic diseases, so things like type 2 diabetes and cardiovascular disease. It reduces stress and depression, and it improves sleep. So it actually reduces insomnia. So we're hitting on a lot of those lifestyle factors. And when it comes to the brain, we see really big benefits of exercise. So you've probably heard this before, but one of the mantras that we use in behavioral interventions is that what's good for the heart is good for the brain. So 1/4, 25% of every heartbeat goes directly to your brain. So imagine doing exercise, increasing that heartbeat, you're getting more blood flow to the brain. So that exercise increases blood flow to the brain, which results in kind of that optimal cognition. And what we know about people who exercise and what the sort of longer term impact is on the brain, what exercise does is it enhances functional connectivity, which are just those connections between different parts of the brain in the frontal, posterior, and temporal brain regions. So these are the parts of our brain that are important for things like reasoning, visual analysis, and memory. It can also support neural systems involved directly in memory. So exercise can help our memories. There's also evidence that physical exercise increases neuronal connection density. So again, we're talking about those connections between different parts of the brain. So we want more connections and we want them to work really well, which is something that exercise seems to help with. So then how much exercise should we be doing? In terms of some guidelines for folks, the American Heart Association has put out guidelines that people should be doing 30 minutes of moderate aerobic activity 5 days a week. So moderate aerobic activity is like walking at a quick pace, swimming, those types of things. I think the rule of thumb is that you should be able to talk, but not sing for it to be a moderate activity. Alternatively, if you wanted to do vigorous activities, so that's activities where you're having trouble kind of keeping a conversation, that would be 20 minutes, 3 days a week. So if you kind of turn the volume up on how hard the exercise is, you can exercise a little bit less. Obviously, if you're someone that's not exercising right now, you'd want to work with a doctor to figure out what that right balance for you is. And before we move on, what I usually recommend to people is try to exercise more days of the week than not. So don't worry so much about these numbers, because what's really great about exercise is anything helps. So there's this, what we call a dose response relationship. So the more you exercise, the better it is for your brain, but even a little bit can make a big difference. And I also, whenever I talk about exercise, I want to also talk about the role of vascular risk factors. So these are things like high blood pressure and something that's important to keep in mind. This is kind of a joke in a slide, but it's also true that high blood pressure is even riskier than swimming with sharks. So high blood pressure is not something to sort of ignore or not address. Same thing goes for things like hyperlipidemia, diabetes, heart disease, and sleep apnea. So all of these vascular risk factors disrupt blood flow to the brain and over time can affect your cognition. So these factors lead to an increased risk of stroke, and especially so stroke and also something we call TIAs, which are kind of silent strokes. They can lead to an increased risk of MCI and also dementia. So if you are someone who has some of these risk factors, make sure to work with your doctor to help get them under control. And in terms of physical exercise, I always like to leave people with kind of what can I do today? What is a practical step I can take? And some of the small changes that we can make today to help improve this part of our sort of brain health regimen are to improve management of those vascular risk factors. So if you saw something on that list that applies to you and you haven't been to the doctor in a while for it, it's worth following up and making sure that it's under control. Incorporate exercise into your daily routine. So this can be something as simple as taking the stairs, when you are going to a friend's house instead of taking an elevator, or, something like that, where you're kind of embedding that exercise into your daily life, can be really useful, because then you don't have to think so much about it. It's just there. As I said before, do some form of exercise most days of the week. So even if you don't hit that recommended amount, that's okay. More, or any piece that you're doing is better than not doing anything. And then finally, finding a fitness partner. So having someone that you can do exercise with can be really useful to make sure that you're able to, engage in it, and it can kind of give you that accountability. All right, so the second part that I'll talk about today is cognitive stimulation. And as you'll see, this is kind of an open spectrum of things, but we'll talk about what those different things are and kind of what you can do. So cognitive stimulation throughout life and even in late life leads to lower incidence of dementia. It encourages social engagement, and it improves mood and reduces boredom. So this, again, is one of those factors that can kind of synergize with other lifestyle factors to help our brains. And when we talk about cognitive stimulation, what we know is that people who are engaged in more cognitively stimulating activities tend to have greater brain volume, density, and functional connectivity. They also have more cognitive activity also increases our cognitive reserve. So if you look at the graph on the right, what that means is that folks who have that higher level of cognitive activity, both in early life and in later life, tend to kind of start a little bit higher in terms of their overall cognitive functioning, and they tend to kind of stave off decline a little bit longer. And that's important because as you can see, the dotted line versus the dotted line is someone with a low reserve, the not dotted line is someone that has a higher reserve. And if they both go on to develop dementia, the person with that higher reserve, it takes a little bit longer for those symptoms to start, and they're slower to come on. And that's really what we want. We want to kind of delay that as much as we can. All right, so what should you do? So the most important thing when it comes to cognitive activity is to engage in something regularly that is challenging and fun. And those are two really important pieces. So we want it to be a little bit difficult, and we also want it to be something that you really enjoy. So we try to engage in cognitively stimulating activities for at least 30 minutes, 3 or more days a week. And what counts as cognitive stimulation? So this can be many different things, and it's kind of one size does not fit all. So we have to kind of find those things that we find challenging and fun. So for example, for someone who has never learned a language before, that might be a great example of something that is difficult because it's not something you already know. And it could be fun because maybe you're taking a trip somewhere and you want to learn the language. So finding those things that kind of have that balance is really key. Some ideas for things that you can do include learning something new. So this can be a skill or a hobby. You can take a class. So this could be something like a cooking or an art class, or even a more sort of academic class. So through like Osher Lifelong Learning Institute, which we have here at Emory, you can learn new skills, new classes, things like that. Learning new languages or how to play musical instruments is another example of a cognitively stimulating activity. We always like to encourage people to engage your brain with someone else. So going at it alone can be difficult. So sometimes it's helpful to kind of have that partner, especially if it's something you're both interested in, to be able to kind of add in that social piece as well. And then the last thing to keep in mind is that you can choose activities that involve both mental and physical engagement. So for example, if you're trying to learn a new sport, let's say you're trying to learn tennis, you can have both that physical and that mental activity kind of wrapped into one. And again, you get that synergy between them. In addition to those more sort of informal cognitive stimulation techniques, you can also engage in formal cognitive training. So there are a couple of different forms that this can take. Within the Cognitive Empowerment Program, we actually kind of take two approaches, which I'll talk about here. But the first type of formal cognitive training that you can do is by using computerized programs. So these utilize structured practice on cognitively challenging tasks. So the one that we use within the Cognitive Empowerment Program is called Brain HQ. It's by Posit Science. There are a lot of these programs out there, and this is a place where I just want to give a disclaimer that if you are going to do some sort of computerized program, you have to be a really savvy consumer. As I said, we use Brain HQ by Posit Science because there's kind of the most evidence behind it. But this is something where there has been a lot of debate about how useful these programs are for our brains. So just be aware. Some of the pros of this type of cognitive training are that they can be really visually appealing and some people find them really fun. It also adapts to your level of performance. So it definitely checks the box of challenging because it kind of gives you that really difficult, it finds the right level of difficult for you and it adjusts. Some of the downsides of this type of training are that it can be expensive. The effectiveness is mixed. So the programs are not equivalent. So some programs work better than others. And right now there's not enough data for us to really know why that is. And they can be difficult to engage with. So a lot of these programs are not written for people with cognitive difficulties. So the instructions are not super clear and they can be a little bit hard to do. Another type of formal cognitive training is called compensatory strategy training. So this involves learning new strategies to support everyday cognition. And some examples of this that you guys may have heard of or been a part of include calendar training, which we've done here at Emory for quite a while. You can also do things like learning different strategies through structured programs. So things like attention strategies or strategies for decision making. Or there are some sort of more informal strategies that are out there. So things like the method of loci that you can like watch YouTube videos about and learn about. So some of the pros of compensatory strategy training are not the ones that are on here. So some of the pros are that it's really individualized. So you can really say, you know, I have a really hard time remembering my medications in the morning and find a strategy to work on that really addresses that. The other pro of this type of training is that it can be really, it can sort of help that daily functioning a lot more than the computerized training. So it really attacks those daily activities. Some of the cons are that it takes a lot of effort, so it takes a lot of practice to do, and you typically need a sort of therapist to help you. You need someone to kind of walk you through and teach you those skills and practice with you. So in the end, when it comes to cognitive stimulation, we want to find the right combination of these things. So the ways that you can get more cognitive stimulation are to increase that stimulation in your daily life through learning new skills or hobbies, increase social stimulation. You can use computerized cognitive training or compensatory strategy training. And this is where you have to kind of try things out and figure out what is best for you and for your situation. And in terms of what you can do today, you can identify a new skill that you'd like to learn or a hobby that you want to be more involved in and try it out. You can join groups or clubs through places like the Alzheimer's Association or other venues. Maybe start a weekly card game with a friend or call a loved one to chat. All of these can increase your cognitive activity. And then some key takeaways from this part of the talk. Number one is to make sure to manage those modifiable risk factors and increase physical and cognitive activity. So those are kind of the steps that you can take today to make it, to move toward better brain health. Small changes can make a big difference. So even if you're thinking, oh, wow, I don't know how I would ever exercise 5 days a week, that's okay. Take a small step today. Take the stairs instead of the elevator. Find those small changes that over time will accumulate to a big difference. And then the last point is just that it's important to find things that work for you. So brain health is not one size fits all. And often what we see is that people have to kind of try things to say, oh, I really like this, but I don't like this as much. And find those things that you like and that seem to work for you and really go with them. So keep using them and find ways to incorporate them more. I think that's all I have. Yeah. So I think that's my part. So any questions?
Yeah, thank you to both Dr. Goldstein and Dr. Vickers. This was really great. One of our most common questions that I see at Brain Talk Live and CEP Community Live every week is, what can I do to reduce my risk, or what can I do to improve my cognition? And you guys just touched on so many things. So I'm hoping everyone found this really helpful. One other thing that I know that Dr. Goldstein and Dr. Vickers mentioned is that a lot of the things that they mentioned we're actually doing right now in the cognitive empowerment program. And the primary goal of the empowerment program is to increase people's sense of empowerment, feeling that they have control over their healthcare and everything like that. But also some of our other goals are also to ideally slow down symptoms and increase this cognitive ability and physical activity. So that is part of our program that we do here at the Cognitive Empowerment Program every week. If you are interested in getting involved in our research study, I will post a link down in chat on how to set up an appointment at the Emory Cognition Clinic. Currently, all of the participants for our study are referred from a clinician at the Emory Cognition Clinic, and that's the way to get in right now. And anyways, thanks again. Great presentation, Dr. Goldstein and Dr. Vickers. If anyone has any questions, please post them in chat, either in the chat or in the Q&A, and I will take a look at that right now. So I saw one question come in.
Sorry, I can't. Sorry about that.
I saw one question come in, which was what is lipidemia? And that's just high cholesterol, correct?
Correct.
Correct. Yeah. All right. Okay, so we had one question come in, Dr. Vickers, about Brain HQ versus Lumosity. Is that they found Lumosity a little bit easier to follow? Do you have any opinion, or is there any research out there on comparing the two?
So I'll give my answer and then I'll let Felicia correct it and add to it. But so the way that I think about this, so there's much more research evidence behind Brain HQ than there is Lumosity. And it seems like even within, so for example, even within Brain HQ, there are many different types of activities, and there are certain activities that seem to do a better job than others. So really what my understanding is of computerized training and kind of how to think about it is that there are some tasks that seem to perform really well, and there are others that don't. And I think what it is with Brain HQ is that they have a group of these tasks that seem to perform pretty well, that we haven't seen that sort of evidence in Lumosity. That being said, if you can't engage with it, it's not going to help you. So and I will be the first to say that Brain HQ, getting into it is very confusing. That's part of why within our program, we actually sort of walk people through it, because those instructions are not great. So if you're someone that's saying, I won't do it if I'm doing Brain HQ, then, that's probably not the right route for you. What I would then say is that if you're someone who really enjoys Lumosity and you find it to be something that, it gives you some joy in your day, that's great. I wouldn't necessarily say that you would expect to see brain changes from it. I don't know, Dr. Goldstein, do you have any additional thoughts there?
I totally agree. I think the reason we picked Brain HQ is because of the greater evidence behind its efficacy and the fact that it's been used in a number of different clinical trials, like as an outcome of exercise benefits or diet benefits. And so we felt more comfortable using it because of the evidence behind it. Not to say that Lumosity is not okay, but we just like the fact that there were more papers on the Brain HQ.
All right, so we have another question coming in now. Switching over to medication, is that one of the things you guys mentioned was trying to reduce medication that have a negative effect on cognition. So how do you know if your medication has a negative effect on your cognition?
Dr.
Well, a couple of ways. One is to look at the side effects. You can plug in your medications into WebMD or one of those and see what the side effects are. the FDA requires that every single possible side effect be mentioned, from, numbered from the highest to the lowest. So even if it makes you, one person sneezed in the clinical trial, you'll see sneezing maybe listed below, but not everybody gets that. I think it's important to look at the big ones on top and not worry so much about the smaller ones. Something I see commonly in my practice is people having multiple care providers, different doctors. Medicine's become so specialized nowadays. My father was a general practitioner and he did everything. Nowadays, you get referred to every single specialist for any single problem, and they sometimes don't look at what the other doctors are doing. So people will come into clinic on multiple medications, and some of these can have negative side effects when they go together. So you also want to make sure that any doctor you see has all your medications and pays attention to possible interactions among those medications. And those would be the big ways that I would think things are important to consider about medications. And Kayci, do you have other thoughts too as well?
Oh, I was going to say the exact same thing. I think it's always great to do your own research and to kind of have a sense of what some of those medications may be that you're on. But I think at the end of the day, going to the doctor and having them, giving them, making sure they have a full picture of everything that you're taking and really working with them to say, okay, let's try weaning you off of this and see what happens. And doing that in that controlled way with your doctor is really important. So that's always my recommendation is if you're someone that's concerned about that, talk to your doctor, make sure that they know everything you're on and can really have that full picture.
Yeah.
Related to talking to your doctor is that some people were asking that they have a parent with dementia and that they want to know when they should start getting involved in neurological studies. And so they're really not sure, are some of their issues like just age related or like, is it normal? Or do you guys have any recommendations on like when to start the process of maybe like talking to a doctor about that?
I know what I would think all of our doctors would say as early as possible. We have moved away from, in my practice, and when I started at Emory, most of my patients coming in already had dementia and they had Alzheimer's, and there's, just that was the bottom line. But now we know that getting it earlier and earlier, the changes of Alzheimer's occur decades before they actually become clinically manifest. So the field has moved towards the preclinical stage. I would say if you have a family history and you're concerned about yourself, get involved in research. And we have a number of trials that do involve people with a preclinical stage, and recommend that you consider it. Kayci? Yeah.
I think another piece of that, I think it's a lot of people may sort of hesitate to say, I don't think that I have a problem now, but I'm noticing these changes and I know I have this family history. And so I don't want to go to the doctor yet, or I don't want to, and I think it's important to know that that's okay. It's okay to go to the doctor for that. That if you're someone, especially if you have that family history and you're noticing some changes, or, you're just concerned about it, starting that process earlier rather than later has a lot of benefits. And a lot of times your neurologist is going to be a good person to hook you into research that's going on. So they may know some options that you wouldn't otherwise have as well.
What helps Kayci and I as a neuropsychologist is having that baseline. And so many times I see a person and I wish I had had a baseline to know where they were, to even be able to tell whether there is a change or not. And that's really important. The other thing I want to say is not to let your physician poo-poo you. I hear a lot of times, and not with ours because they're sophisticated, but if you're noticing something and your doctor just says, you're just getting old, everybody has forgetfulness, but you're, like Kayci said, something's wrong, insist that you get worked up. Don't just take no, you're just a worry wart for an answer. It may be that there's nothing wrong, but it doesn't hurt to get it checked out. Because there are treatable causes. That's the other thing. I mean, not everything is Alzheimer's. It could be medication. It could be a vitamin deficiency. It could be 9 gazillion things. It doesn't mean you have Alzheimer's. And if it's treatable, it could be you have sleep apnea and you're not aware of it. So bottom line is, if there's something that we can do to make it better, it's important.
And that actually answers
The earlier, oh, sorry. I was just going to say that with that as well is all of the evidence right now is suggesting that the earlier that we know something is going on, the more we can do about it. And so I think that's just a really important point to keep in mind too, is that number one, it's not always Alzheimer's disease. And number two, if it is, you want to know, the earlier you know, the more these like lifestyle factors and things like that can help.
Yeah.
I say that, sorry.
Yeah, all I was going to say was that this also kind of relates to another question that we had. Was someone just asked why they need to be referred through the clinic in order to participate in the the cognitive empowerment program. And I just wanted to just highlight how we were saying is that that at Emory we have a lot of different research for people that are preclinical, that are mild cognitive impairment, that have progressed into dementia, and that we have different studies for everything. And the clinic helps our patients find like which study is appropriate for them, and to rule out that some of these things that Dr. Goldstein was mentioning. So that's why we go through the clinic. And if people are interested in getting setting up an appointment, I also posted the phone number and website to set up an appointment for the cognitive clinic here at Emory.
Matt, the other thing people can do is if you get on the Emory website and go to the neurology department, there's a link for the Alzheimer's Disease Research Center. And in there, there's something, get involved in research. And that's what I'd really recommend if you are interested in being in research or knowing about what's going on at Emory or being on a wait list for something, go to that link and find out how you can register and get involved and screened, and that's a really good resource as well.
Someone just had a question that when they talk to their doctor, they feel like they are only being assessed at a very surface level, and that they would like they would like to feel more confident for their doctor to look a closer look. Is there anything specifically you would ask your clinician to look into, or is there anything that you would do to advocate for yourself for a more thorough evaluation?
See another doctor. Really?
I was gonna say, I think it's an incredible question, and I think it's really important. But I agree with you, Felicia.
No, I'm sorry, but if your doctor's not taking you seriously and you really want to get an evaluation, you should be able to get one. I mean, they should be able to refer you and find a doctor that understands the need to be seen and see that just go to that doctor, I think.
I will also say, if if you're someone that is concerned specifically about Alzheimer's disease or about dementia or other neurological issues, like if you're noticing a cognitive change, I think it can be really helpful to actually see a neurologist. PCPs don't always have that specialty. And that can be something that it's not necessarily that they're not doing a thorough job. It's just that that's not kind of their MO. And I also recognize, it's difficult to switch doctors. It's difficult to find good doctors. And so I think, just that would be my recommendation. If you're someone that is specifically worried about Alzheimer's disease, or maybe you have a family history or noticing some changes, to go to a neurologist.
Mm-hmm. Great.
You guys would know better than me. If people followed the phone number and the links that we've suggested for getting in touch with like the neurology department, the people there would probably be able to help them find a PCP within the Emory network, correct?
That I don't know, Matt.
Okay.
Can you say that again?
If you went to our neurology clinic, would they be able to help you find a PCP, like a primary care physician in the Emory network?
I'm not so sure. Probably the other thing to do would be to directly contact the medicine department, the PCP. I know at Wesley Woods has a department of medicine. I wish Dr. Parker, I think she was on earlier, but that might be the most direct route, really, to just call the Department of Geriatric Medicine at Emory and explore a bit and try to get an appointment through them rather than through neurology. I think that's the route to take. And then if the doctor feels at Emory that you do need to see someone, they will then refer you to neurology directly rather than go to neurology directly. I think that the neurologists are requiring an Emory referral, Matt.
Yeah.
So I think because of bandwidth at this point.
That
So
makes sense. Well, we are coming up on 4 p.m., everyone. We are, today's session has been recorded. We still have the recordings of the other weeks. I know people have been asking about that. We are actively working on getting those uploaded onto the internet for people to watch afterwards. If we cannot get them on the same YouTube channel as the Brain Talk Live, then we were just going to be starting our own YouTube channel. I promise we are working hard on that, and we will be trying to send out a link for that afterwards. Thank you, Dr. Goldstein and Dr. Vickers. This is a great presentation. Found it really informative. I'm hoping everyone else did. And yeah, thanks for everyone for
thank
coming
you.
by.